I think is an expert in complex interventions. And in my humble opinion, I think is one of the best CT operators in the world, certainly in Italy. So Roberto, I really appreciate you taking the time to share with us some tips and tricks in rotational atherectomy. For those of you who joined late, it's going to be very case-based. So after every case, we're going to stop. There'll be an opportunity to ask questions about that specific case. And Roberto will be answering some of the questions about that case. We'll have a discussion about each case as we go along. It's all yours, Roberto.
Okay, so thank you very much, Azim. Good morning to everybody. Thank you for your really kind words. We can go on with the, as you can see, if you can see the presentation, this is the title. We know that calcified lesions are the worst enemy for interventional cardiology treating coronary lesion. And we have to face every day, in everyday practice, this kind of lesion. We know also from guideline, this is a 2018 European guideline on myocardial vascularization, that lesion preparation is essential, is critical for successful PCI, and rotational atherectomy may be required in this lesion with heavy calcification. And we know from the epidemiology that we have calcified lesions are related to the aging of the people to multiple risk factors, as hypertension, dyslipidemia, diabetes, are independent predictor of coronary calcification. We have like more or less to 20% of our patients in the cath lab, and the prognosis is linked to unfavorable outcome. So with the aging of the population, calcific lesions are rising in everyday interventional cardiologist activity. This is some data about the difference between if we have no calcification in gray, moderate in yellow, and severe calcification in red. This is the relationship with outcome. We have an increase of death, we have an increase of MI, we have an increase of MACE. This is a Horizon MI trial. Another study is a meta-analysis from 7 contemporary trial, more than 6,000 patients published 5 years ago. And we can see that calcium is predictor of worst outcome in terms of death MI and revasc on the right side. We have many devices we can try to treat and prepare lesion with heavy calcification. We will discuss about rotational atherectomy. This is the topic of our discussion. We have some, last year, 1 year in 2018, was published a randomized trial. The name is Prepare Calc. And in this trial, we have seen was a randomized trial between rotational atherectomy in primary rotational atherectomy versus preparation with the drug with the modified balloon and then stent, or rotational atherectomy only in bailout. We have seen no difference in mortality, MI, and MACE in 9 months. But if we can go to see the crossover of this kind of patient, 16% of patients from the group, the 100 patients of modified balloon, they cross over to the rotational atherectomy group. No one patient from rotational atherectomy crossed to the other group. This is important. And also the strategy success, you can see from 81% of modified balloon group to 98% of rotational atherectomy. Also, the outcome at 9 months, any vascularization, we have a 21% of modified balloon versus 8%. So we have seen some difference in between the two groups. And the reason for crossing over in the modified balloon group were lesion not crossable by any balloon, lesion not crossable by a modified balloon, lesion not dilatable, or stent not deliverable despite adequate predilation. So we have this data that is quite strange. You can see this was the final data of this study. The group with modified balloon have less duration of the procedure on respect of rotational atherectomy, and the fluoroscopy time was less also in the modified balloon and more in the rotational atherectomy. So this is something that strange that we have tried to understand. So the question is, are these interventions in this randomized trial performed on true severe coronary calcified lesion? In other words, they were not selected too much easy case for this randomized trial, because we have published some years ago with Azim, with a group of Azim Atib and Antonio Colombo and the group of Japanese people and our group. We have published this rotate multi-center registry that is a sort of real-world evaluation of PCI treated with rotational atherectomy. If you can see this registry, we have more than 700 cases, and in this registry, that is a really real-world one, we have more than 50% of case that was primary rotablator. And we have some, in our hospital, we are 74% of primary. In the San Raffaele Hospital, the group of Azim and Antonio Colombo, more than 70% of primary rotablator. So in this situation, you can see that the procedural time was less in primary rotablator against the provisional. You can see 65 minutes against 84. Also for fluoroscopy time and contrast volume. So these data in the real world are completely different from the one of randomized trial. Let's go to in practical. I have selected 5 situations, and I think it's in which is interesting to evaluate the rotational atherectomy. So these are my top 5 tips and tricks for this kind of treatment. The first one is really extreme calcification. This is a case of a woman, 79-year-old, with CKD in dialysis, 3-vessel disease that was refused for CABG. You can see we have an occlusion of the circ, CTO, diffuse heavy calcified lesion on the LAD. This is another view. Normal ejection fraction. So this case, do you think that someone will randomize this patient to the Prepare Calc trial? I don't think so. We start with the primary rotablator with 1.5 Burr. That was unaffected. You can see here, I have a multiple run. It's important to stay no more than 10, maximum 15 seconds for each run. And if you are not able to cross the lesion, you have to go back and stop to rotate at the level of your initial position. I tried to run many times, more than 2 minutes of run, no way. In this situation, another tips and trick is to increase the speed of your rotablation. I went up to 200,000 of speed with 1.5 Burr. So in this situation, what can we do? We have a failure of this rotation with 1.5 despite high speed rotablation. So we have only one way to decrease, so downside the Burr. This was 1.25 Burr. So I have a mistake. I under evaluate this lesion, and in this case, I went with 1.25 Burr high speed from the beginning. And you can see this is the first run in which I was able to cross. It's very important because someone made the mistake to say that with the small Burr, you increase the risk of entrapment. It's not like that. In this situation, the problem is that you have to be careful to go back with your Burr and to stop to rotate proximal to the lesion. If you stop the burr distal, this is a big problem. You can have entrapment. In this situation, after that, I went to the previous burr, so upgrade to 1.5 burr, 170 run, 170,000. You can see. After the first burr, the second one gets easily, and then have a good pre-dilatation with non-compliant cutting balloon and then stent implantation. This was the good final result with the IVUS evaluation. So this is a very important point when you have extreme calcification, like in this case. The take-home message is if the first burr failed to cross, the first step is to increase the speed up to, you can go up to 200. And the second step is to downgrade the size. So this is a good option to can solve the procedure. So if you can have some question.
Yeah, I think that's a great place to maybe stop and have some questions. Miguel, while Miguel's coming on, something the fellows always ask, Roberto, radial versus femoral, and what, inside a 6 French guide, what do you feel comfortable using, as in what burr sizes do you feel comfortable using?
Perfect. This is a very important question, because at the beginning of our curve of to learn, our learning curve to do rotablator, we also always we decide to have elective rotablator with femoral approach. This was good to start, but now when you have a good expertise on this procedure, we perform more than 90% of rotablator by radial. We have no issue to do radial. Like CTO, we can do retrograde CTO with biradial approach, no problem. And the problem of size, this is very important. I always use a Medtronic launcher, that is a large lumen guiding catheter with a 6 French. You can go up to, you can rotate up to 1.75. So with 6 French, you can rotate more than 90% of cases. If you need to rotate with the burr, big burr, like 2.0, you need to have a 7 French, because the inner lumen of 6 French launcher is 1.81. So you can go with 75. The 7 French large lumen is 2.06. So you can go up to 2.0. If you need to go with a bigger burr, but now we don't use bigger than 2.0 burr in any case. You need to go with 8 French, but I think that this is the good advantage, the great novelty of shockwave. When you need to, when you rotate and the result is not so good with the sequent non-compliant balloon or cutting balloon, you need to go with shockwave. You don't need to go with bigger burr, because in this situation you increase the risk of complication without any effect.
Yeah. Thank you for saying that. Especially, I keep telling my fellows about the 1.75 and 6 French. We used to do it all the time. So I'm glad you confirmed that too. There's some questions from the chat that Miguel, I'm sure, will pass on to you.
Yeah, Dr. Garbo, thank you. First, a question that also another of our incoming fellows for next year asked that I had. You mentioned in the beginning that you had to switch to a 1.25 because you had miscalculated the size of the burr that you needed, perhaps. And what is a good way to size the burr? What is a good tip or a good trick to size the burr adequately, especially in this type of very calcified lesions? Yeah.
Normally, I can tell you what I'm doing. Normally, I use 1.25 only in CTO. So this is my because I think that CTO, when you have you are not able to cross a CTO with the balloon or to dilate. In that case, you really need the smallest burr you have. Or in another situation, I will show you like stent under expansion that I used in the past, but we discuss later. And normally in other situation, I like go with 1.5 millimeter burr. The only situation which you can go with the 125 is like this case. You have a very long calcified lesion, huge calcification. In that case, I think it was a good idea to start with 1.5, but if you fail to cross, you can switch very fast to 1.25 to downgrade. But normally the tips and tricks to increase the speed is very useful to. Because when you increase the speed, you have two advantages. The first one, you facilitate the crossing of the burr and you reduce the risk of entrapment.
Okay. 3 more questions in this case before we move on. One is a very good question that just came up, which is, do you change that approach of 125? I mean 1.5 up front, depending on what vessel you're facing, RCA versus LAD, for example?
No, no different, no.
Okay, and then do you see more risk of no reflow if you use higher speed?
In my experience, we didn't see the increase of no reflow. The problem of no reflow, we have more than 3. I think no, we have in the last 10 years more than 500 of rotablator. We have only 2 cases of no reflow, and was huge calcification and with a big burr. So the speed really normally it's correct that you can go with not too high speed if you are able to cross, and if you have a big burr, you need to go with the reduced speed.
Yeah, I think we've got some feedback from one of our people. They may be too close to somebody else. I'm going to let Antonio make a comment, and then we're going to go to the next case, Miguel. There's still some really good questions here about osteal lesions and so on. Maybe let's do it after the next case. Yeah.
But
No, Antonio,
can you hear me?
It's coming from you, the feedback. You
There's
too
a lot
close to
of feedback sound. Can you hear better now?
Yes.
Good morning,
Can
Antonio.
Yeah, yeah. Can you
Yes,
hear?
we can hear you.
Okay. I agree with everything Roberto said. A few points. I think I always start with a 1.5. It's not a big deal. If the 1.5 does not go, you use a 125. And you did not open one burr for nothing, because after the 125, you always have to go to a bigger burr, 1.5. Very limited use for 175. If you have the shock wave, I prefer not to upsize the burr too much and use the shock wave. I really believe in a synergistic approach. If the lesion is very calcific, you can make your way with rotablation, and then you get a better result if you use a shock wave and then high pressure balloon. I am very convinced that not only cross-sectional area is important, but symmetry. If you get a nice round symmetry of the stent implanted, you may have a lower late loss. We always look at procedural time, contrast, etc., but we have to improve the restenosis. Angioplasty always fails for bypass surgery because of TLR. So we have to improve the TLR rate. And the only way we have to improve the TLR rate is to get a better immediate result. And the better immediate result is a synergy in calcific lesion, not only rotablation, shock wave, high pressure balloon, IVUS, etc. I don't believe you can do a trial with one device and say that the device is sufficient. Nowadays, you need multiple synergy of different devices.
Roberto, why don't you go to the second case, and then we'll continue some of the other questions that came up during the second case.
Yeah. I want to say hello to Antonio. I completely agree with these comments. They are a very important key message. So this is a uncrossable lesion. This is an interesting case. It was a failure by my colleague in 2 months before. And he told me, we need to go retrograde. So I select this case for you for retrograde approach. It was a course. And I say, okay, but I want to try antegrade to see if there's some way to do. And I crossed the lesion with Gaia 3 in really 5 minutes. And I was happy, say, okay, it's finished. So this case is done. But you can see it's a proximal RCA. We have no way to have a good anchoring. We have a good support with amplats. And that time started the nightmare. No way to cross this lesion with any balloon. So we try any microcatheter. We try with the Tazuna balloon, Sapphire 110, and many microcatheter, Fine Cross, Corsair, with Turnpike Gold and Tornus. Everything was unsuccessful. So we have the Gaia in the distal to the occlusion, no way to dilate. The next step, which is the next step for you. For me, I try to do the laser because we can have laser 0.9 millimeter. This is the laser real time. I push a lot. I do the laser with the eye energy, but also with the laser, you can see the Gaia is distal in the right, but the laser was not able to cross at all this lesion. At this time, I have two possibilities. The first one, going retrograde. We have a good retrograde septal. The second option was try to do rotational atherectomy, but in this situation, you need to remove the Gaia and you need to try to put rota wire. This is a real-time fluoroscopy crossing with rota wire. It takes some, I think, 20 seconds because it was not cut. This angio is a storing of fluoroscopy. You can see the rota wire follow exactly the hole created by the Gaia third. It was fantastic. You see, you have a microcatheter behind and the rota wire floppy. This is the moment of crossing, you can see. And this is the side branch. Then I was able to position the rotawire floppy in a better position in the mid of the right. Then in this case, you need to go to do trapping balloon to remove the microcatheter and to do rotablator. In this case, 1.25 is necessary. This was the rotational atherectomy with 1.25 high speed. Also real-time registration was really easy with the Burr to cross. To cross the CTO. This is the second run, you can see. The rotor wire is in a good position, then this is the final result after stenting. So this I like to show because of this really complex situation, but it's in this situation you can do that. So the take-home message and the uncrossable lesion can be treated with the rotational atherectomy, but you need to know very well rotor wire. So when during my course, I like to show to our colleague that you need to is a wire that Antonio knows by more than 30 years. Is a iron, but if you know very well this wire, you can maneuver. You can move in very well way. You can be able to do something like you have seen in this case, and then you can use rotablator to simplify this kind of procedure.
Great case, Roberto. Maybe I'll ask the first question while Miguel looks at the chat. You know, with Antonio, this used to happen to us a lot, and we always, Antonio used to teach us, before you pull the distal wire, try and get your microcatheter embedded as close as possible into the lesion, you know, whether it's the occlusion and so on, so that the tract you have to wire with your rotor wire is less. So that's often what I do. Some people have mentioned in these situations taking that small balloon, the Sapphire 1.0, and going up to 20, 30 atmospheres until it explodes, the balloon, and that may modify the plaque. Any thoughts on that? Yeah,
this is the granuloplasty technique, and is another option. Indeed, the problem of this case that was so proximal that you have no space to put the balloon outside the guiding catheter in a very good position, and so this was a concern to do granuloplasty. And the second problem is that it's not the risk of perforation that is quite low because the balloon is very small, but you increase the risk of your dissection. Normally, is a technique that we can use during CTO procedure when we are in this situation of uncrossable lesion with and we don't like to lose the distal wire position, and we don't want to change with rota wire. This is one strategy. You need to go up to the balloon rupture. Sometimes you need to rupture more than one balloon. You need to rupture 2 or 3 balloons. After that, you can have a dissection and you can dilate.
Miguel?
Yeah, a couple of questions. The first one from one of our co-fellows, do you, when you have a very proximal or osteal lesion like this, is it safe to start rotablating from the mouth of the guide into the artery?
Important point of osteal lesion, and is from the beginning. Normally, I use rota wire floppy more than 90% of case because we have 2 kind of wire, floppy and extra support. I think that rota wire extra support is essential when you have to deal with osteal calcified lesion like osteal RCA, because in this situation, you reduce the risk of aortic dissection or dissection of the aortic root, or to lose everything when you exit from the guiding catheter. So in some situation, you can start rotate at the end of guiding catheter. You have no problem. Normally, the strategy is to go in Dynaglide. I never go without Dynaglide in the coronary artery. So when I start from outside of the patient, I start in Dynaglide, that is 60,000 run. And in Dynaglide, you can go up to in front of the lesion, then you start to rotate. In this situation, I suggest to go in Dynaglide up to the end of the guiding catheter and then start to rotate the very proximal lesion in the right.
Okay. There is one very specific question about this case, and you know, the person who asked it says, what if the guy was subintimal, and how safe it is to then go with the rota wire and the rotablator without using some sort of imaging?
Yeah, maybe I'll add on to that. You know, there's a lot of, I hear that every time there's a rotablation talk, there'll be someone from the audience or even a few people who will ask about dissection, right? So say you're doing a complex lesion, a CTO, there's some dissection, you go subintimal, and then, but your distal wire is in true lumen. And there are a lot of people who think that that situation is a contraindication to rotational atherectomy. Can you tell us maybe how you see the presence of a dissection and whether you could do rotablation?
Yeah, this is a very important point. The main concept is that when you are not able to dilate the lesion, like in this case, you for sure you are not subintimal, because when you are subintimal, you can dilate very easily because subintimal space is easy to dilate. So this is the first concept. like in this case, we were all the tract, we were intimal up to the end. But the problem of dissection is not when you, because I need to rotate sometime in CTO, also in retrograde CTO. You can rotate, but you can pass through subintimal space with the Burr, but because you need to rotate proximal, because you have huge calcification intimal and not subintimal. In this case, you need to rotate the calcification, but the subintimal space is no problem for the rotablate, for the Burr cross. No way to have a perforation. The problem is that if you, as what Antonio explained us when we were young, the more you increase to have heavy balloon dilatation with high atmosphere before make a rotablator, you have two problems. The first one, that you increase the risk of perforation, because if you go with the 28 atmosphere with the balloon and you are not able to dilate, you increase the risk of perforation, not at the level of the calcium, but proximal or distal. And if you have a dissection, you can have an occlusion of distal vessel, and then you have to put a rota wire and you risk to put completely in the dissection. This is the main problem. So my suggestion is, if you have not a good experience, you don't want to do primary rotablator, you have to try to dilate, you go to 14 atmosphere. If the balloon doesn't open, you have to switch to something different, not go with very high atmosphere.
Okay, Antonio, maybe if you could comment on this whole issue about dissection and rotablation as well.
The classic scenario is that you have a tough lesion, you go with a non-compliant balloon, balloon rupture, you have a dissection consequent to the rupture, you take a new balloon and the new balloon does not cross even if there is a rupture of the other balloon and dissection. At this point, can you do rotablation? Yes, you can do rotablation. In a dissected vessel, you have to be a little bit more careful because there is some risk, but you can do rotablation. So don't use a big Burr, use a 1.5 Burr. I would not use anything more than 1.5, but you can do, don't go too high speed, 150, and you can do rotablator inside the dissection. There is literature, and I studied the field quite deep because I was involved in the legal cases with that problem, and you can find a lot of literature supporting the decision to do rotablation inside the dissection. Nevertheless, be a little bit careful and take some cautions because it's a little bit tricky area.
It's a very important point that you need to have a small Burr. I had some case, I need to rotate with the retrograde RG3 because I was not able to switch with the rota wire. So it's possible to, it's not an indication, but I did. I published that case, so you can do that, but you have to be careful and you have to go with a small Burr and no problem with that section.
Yeah, exactly.
Maybe one last question. We'll go on to the next case. Since this was a right coronary artery, what about, I didn't see a temporary pacing wire. So do you routinely use a temporary pacing wire? I know Antonio likes using aminophylline at times. I've started using pacing through the rotablator wire is my standard. What are you doing?
Yeah, at the beginning we put a temporary PM in every right CT right rotablation, and in the past, and we have very few cases. I think one or two cases in which was necessary to do that. Now at the moment we didn't put the temporary wire because you increase the risk to have a perforation of the right ventricle, any other complication, and is not useful in almost the totality of case. We put a venous sheath on the right femoral artery, and this situation, try to be prepared to that. if during the first run, when we start to rotate, if we have extreme bradycardia, at that time we put the temporary pacemaker and then we go on. But it's really one case every year, so really few.
Antonio, any final comment about the right coronary artery or dominant circumflex and
No,
pacing?
as you said, I like aminophylline. I don't use the temporary pacer anymore. I'm afraid of perforation of the right ventricle. And that's it. And if you have some bradycardia, systole, you make the patient cough, old-fashioned maneuver, it's okay. A little bit of rest, the heart rate, slow, decreases enzyme elevation is good.
So I'll tell you what I do. I pace through the wire, okay, the rotor wire. I make sure that the rotor wire is pretty distal. So if I'm doing the right coronary artery, I get it down into the PDA, hopefully even into a small one of the side branches. I then, get an alligator clamp that connects to the pacemaker. I connect one, either the black or red, doesn't matter, to the rotor wire. And the other one, I take a needle and I go through the skin of the patient near the groin and I connect it to the needle. We've been doing something similar for TAVI and pacing through the wire for TAVI. And so you can do it with the pacing wire as well, with the rotor wire. It actually works pretty well. We had a case this week where the patient would just, every time we rotated, patient would lose all their QRS complexes. And we just pace the patient through the rotor wire. I think before you decide to actually rotate, you have to make sure it actually works. It won't always work. You need to use a higher threshold, like 20 milliamps. If it doesn't work, then you need to have the backup of a venous sheath, like Dr. Garbo does. Roberto, let's go on to the next case.
Yeah.
We really want to see your cases. Thank you.
Yeah, thank you, Azim. So this is a severe situation of a stent under expansion. This is a very nice case of many years ago. I think it was like 2012. And this is a patient that was sent to me by another center. They perform what Antonio said, not a good angioplasty. They tried to put a stent in the circ. They were not able to dilate the circ, and they decided to put the stent. They thought the stent will open, but you can see the result. This is after 3 days. This woman have a recurrence of a severe angina with ischemia in this big circumflex. So I had to treat this patient. You can see the candy wrapper stent with the huge this stenosis in the middle. And so in this case, I had to go with, I decided to go primary rotablator. We didn't have a shock wave at that time. And then I don't know if now at this time you can cross with the shock wave this stenosis of the stent. This is interesting. You can see was a really strange situation, because we have the strut that were not endothelialized because it was 4 days before. So you need to go with the very small burr, high energy, and you have to keep in mind that at the end, when the burr cross, you can see it's like a gun. You see, you go distal, and then you have to be ready to retrieve the burr. After that, I perform I tried to perform IVUS. IVUS doesn't cross. I went with 1.5 burr. And you can see on the right, the 1.5 burr easily cross as a normal rotablator, because the first burr ablate the strut of the stent, and the second burr ablate the calcium. And this is a behavior of normal rotablator with the second burr. You can see again quite easily. Okay, then we perform IVUS. This is the IVUS. You can see all this shadow. Shadow is not normal in stent evaluation, but is the shadow caused by the fracture of the strut behind the calcium. After that, I was able to dilate with non-compliant balloon 3.0 with any effort, and then this was the final result after the stent. And on the upper screen, you can see the IVUS after the new stenting. So this I performed, I think, 15 cases of a stent ablation in the last 10 or 15 years. So it's not an usual situation. Now we have the shockwave. In the past, we have also the laser with the contrast. That was quite aggressive procedure. You can have embolization, so I don't like this. I have 2 cases that were with no reflow, so I prefer this strategy. So take-home message: small burr, high speed. You can have step up, and you have to be really careful to burr entrapment, because if you have an entrapment in this situation, you can be really in trouble.
Great. Go ahead, Miguel.
Yeah, a couple of questions. When do you briefly touched on this, but when do you select laser versus rotablator and under expanded stents? How do you select one technique versus the other? Do you ever use laser anymore?
But I think that's Antonio, if you want to answer to this question. My experience, I start to use at the beginning laser without contrast, and I have no results, no good results. So you have to switch to laser with contrast. Is a sort of explosion, and you open the stent, but you have high risk of no reflow. So in this situation now, at the moment, I have 2 choices: rotablator or shockwave. It depends on situation.
Yeah, Antonio, you invented the technique with contrast. Maybe tell us some tips and tricks.
I like the contrast. Uazim wrote extensively. I like the laser, but I like rotablation. Rotablation is cheap, is simple, nothing wrong, and I think you should use whatever you like. Roberto addressed the no-reflow with contrast. You have to be careful with contrast. Don't use a big laser probe, maximum 0.9, even smaller, and be not too aggressive. No-reflow with air CO2 production by bubble creation is a risk. So I think you have to be careful. But personally, I think you should use whatever you like. The 2 alternatives are rotablation, laser, or shockwave. The problem of shockwave is that sometimes you need the rota first, because the shockwave doesn't cross.
Yeah.
But I think nothing wrong to use rotablation. And also you make the stent thinner. So you decrease the stent strut thickness, which is good.
Nice.
2 questions here about the risks of this technique. One is the risk of no reflow when ablating a stent, and also the risk of thermal injury when ablating the stent.
I think that I didn't have any case of no reflow in this situation, but you need to have very small burr. If you have no, the worst situation, even entrapment inside the stent, because this is really, because we have a stent that is under expanded. If you have a burr entrap, normally it's entrapped distal to the most critical part, and it's quite impossible to remove. So my caution is really be careful that you have to be coaxial. You have to be very close to the sleeve with the burr, and you have to start very fast in order to reduce the risk of this entrapment. So I'm worried about that, and you have to have a very small burr.
Miguel, there was another question about burr entrapment, but we'll take it with case 5. Maybe you can ask that one.
Yeah.
I had maybe one practical question for both you and Antonio, because I've seen different practices in different parts of the world. So when you're flush, when you're doing rotablator, do you use Rotaglide? Do you put vasodilators in the bag, nitride, nitrates? And the second question is, do you flush with saline after every burr run?
It's for Antonio, yeah.
Antonio, maybe you.
We put only saline and heparin. We don't have Rotaglide in Europe. I don't know if recently came, but we never had Rotaglide. You have it in the United States. If you have it, it's fine to use it. Regarding the flush, we flush with contrast because we take a check, but no particular. But I think it's very important to take a check to make sure that you have no reflow and act immediately. You don't want to sit on no reflow. No reflow is to be corrected, and don't do an extra passage if you have no reflow. Come back and treat no reflow, and then you continue.
Maybe because there was a question earlier, just very quickly, very briefly, Antonio, how do you treat the no reflow associated with rotablation? What do you do?
I inject distally. The easiest, I take a balloon, I break a balloon, and I inject from the lumen to inflate the balloon. I inject nipride. I like nipride, adenosine. These are the two drugs. Sometimes a little bit of tears of adrenaline, not much, just a little bit, and nipride. Some people have injected blood. I don't know, they are anecdotal report, but I think nipride and adenosine. And very distal, not to the guiding catheter, selective in the vessel and in the distal lumen of the vessel.
Roberto, anything different before we move on to your next case?
Oh, I have the same strategy. It's important that when you start to rotate, the pressure is more than 100, the pressure of the patient, because if you rotate with a low pressure, like 80 or 90, you increase the risk of no reflow. So this is important. When you start your procedure, maybe you can do some small amount of noradrenaline to put the pressure more than 100, and you reduce the risk of no reflow. If you have no reflow, nipride, adenosine, or like in cardiogenic shock, we have great result with low dose of adrenaline, like 50 microgram distal. It's great to solve that. So I have the same strategy than Antonio.
Why don't you go with your next case? Thank you.
Okay, so we have mother and child rotablator is an excellent technique with the mother and child, and the combination with the rotablator and mother and child. This is, I think, two cases, interesting case of this strategy. This was a female with previous treatment. You can see in urgent situation, left main circumflex, and then he had this huge calcification on the diagonal LAD, and that we cannot leave like that. So we need to treat, but we have a stent in the left main that was recently plus by colleagues. So in this case, we put Gaizila 7 French and the distal to the stent, and we can do rotablator in the diagonal branch. You can see here. It's important that with the mother and child, we have some problem of inner lumen, as Azim explained with the before. So we need to go with the 7 French maximum 1.5. And then this is the second ablation. Then we can go to the stent implantation, and then a rotablator of the LAD with the same technique. And this is the final result with the bifurcation stenting in LAD and diagonal and IVUS for this evaluation at the end. So mother and child 7 French and 1.5 Burr is possible. You have you can use child and mother as proximal protection, and it's better to assemble it outside of the patient you assemble the burr and the mother and child outside of the patient, or if you have the guide extension in the coronary artery, you can do also in that position. You have to be careful about the transition of the guide of the device. This is another case of another old woman, left main LAD, treat 4 days before and for STEMI. We have another lesion in the middle AD. You can see here. This is outside. So as the crossing of, you have the guidezilla in the LAD, and you can see that you can cross with the burr at the level of transition, and then you can go on with 1.5 burr and stenting with excellent final result. The last case of a mother and child is a young man with the non-STEMI, multi-vessel disease, all calcified. He have a rotablator in the right, a rotablator in the circ. We need to treat LAD and this first diagonal branch. We start with A French. You can see here, this is a really complex situation, bifurcation lesion. I start with 8 French guiding catheter. I rotate the LAD with 1.5 and then 2.0. This is the second burr. This is the result, and then I try to avoid to rotate the diagonal branch, but I was not able to dilate the mid part. So in this case, I didn't treat the bifurcation. I need to rotate the diagonal, but I don't want to lose the wire in the LAD. So I take a guidezilla 7 French inside the 8 French guiding catheter, and the wire in the LAD is alongside the guidezilla, so is outside of the guidezilla. I published this case with the first case in a first-in-man case of a dual wire in a rotablator. We have one wire in the LAD, and the guidezilla puts to treat the diagonal branch with rota wire in the diagonal branch. You can see here. I was able to rotate the diagonal and to protect the LAD. After that, DK crash, left main LAD diagonal, kissing balloon, IVUS, and etc. Good result in this really complex situation. So that means that mother and child, the rotablator is a very useful technique in many situations.
That is very cool, Dr. Garbo. I have a couple of questions, and one came up here that is related to mine, which is the approach in general to rotablation of bifurcation lesions, especially when you're treating left main bifurcation, because if you know, often you have to remove the wire from the first branch that you rotablated to then put it in the second branch, risking complications if there's a dissection or there would be closure of the branch that you just rotablated.
Yeah, this is an important question. You need to plan very well the procedure before. And in a case like this, I was sure that if I need to treat the LAD, the diagonal branch, and I have to do the bifurcation, the only way was to do in this situation. Normally when I have bifurcation like a diagonal and LAD, like a small diagonal, the first rotablator I perform is always the side branch. So I put the wire in the diagonal, I rotate the side branch, and then if I need to stent in the proximal diagonal, I stent the diagonal, and then I move the wire in the LAD, and I rotate the LAD, and then I do the bifurcation PCI.
Yeah, Miguel, this is a question that comes up all the time. I want Antonio to comment because there's always the question when you have a true bifurcation calcific and you ablate towards one branch, will you lose the other branch? Okay. I must admit, we did a lot of true bifurcations, and I can't remember a case where I saw it. I actually, we thought many times we need to look at, and Roberto, maybe something we need to use a fellow to look at our rotate registry and look at the true bifurcations in there to see if it ever happened. I don't remember a case. I don't know, Antonio, you've done this longer than us. Do you remember a case?
No, no, as a matter of fact, of course, something that never happened will happen, but so far I need to live a few years more, but it still did not happen to lose a branch. As a matter of fact, when I cannot wire the diagonal, one strategy that sometimes work is to rotablate the LED, and then you can wire the diagonal. So
modifying the bifurcation.
I would say the other way around. So don't be afraid to take the wire out, because usually, but if it happens, write me an email, because we need to collect cases.
Roberto, I like the trick of the mother and child to, if you need to keep a wire in for some reason. Now, after your report, there've been some reports of people protecting the other wire with a microcatheter and still burring next to a microcatheter. Any thoughts on that?
Yeah, the problem is that when you have a microcatheter, like a microcatheter in the LED, and then the Burr, you are not able to stay in the guiding catheter in the 8 French. It's too bulky. This is the problem. If you try to evaluate, because you have the microcatheter and the rotabur and the inside of the guiding catheter is too bulky for that. This is the problem. So you need to have 8 French, and I have concern about the problem of rotate the microcatheter, and I never do this kind of strategy.
Miguel?
Yeah, couple of questions. First is a very simple one for the transition point inside the guide going into the guide. Still, you dynaglide, right?
Yeah.
Okay. And then the other question is, when you're doing true bifurcation.
Also because, sorry, I was remember about with the question of Azim. In CTO, we have some case of retrograde ipsilateral approach, and the only mother and child that can stay together with the microcatheter is the 5 French. Okay. So inside an 8 French, you can have a microcatheter and mother and child 5 French together.
Okay. Thank you.
Sorry.
Yeah, no, it's okay. When doing a true bifurcation, you mentioned you do the side branch first. For example, in a LED diag, what is the reason for that?
Because normally when you go to rotate, as Antonio said before, when you have to rotate the bifurcation with the calcium, you go into diagonal. You rotate proximal to the bifurcation versus the diagonal. You have normally it's quite impossible to have an occlusion of the main vessel. Okay, and so in this situation, if you can cross both branches, normally I prefer to select first the diagonal, and I can stand the diagonal in the not across the LED for sure, but in the proximal diagonal, and then I go to the LED to rotate the LED, the main vessel. And then I don't move the wire from the main branch. I cross again the diagonal, and I finish the bifurcation with culotte or mini crash or other technique.
So the equivalent in a left main bifurcation would be doing the circ first.
Yeah, the left main. Yeah, normally it is a possibility. But if you think that you want to do the simplest possible in the simple situation, you can try to avoid. If you want to avoid to rotate the circ, this I told you in situation which you want to rotate both branches. Okay, if you need to rotate both branches, I will start with the circ first, and then I rotate the left main LED. But normally, when you have a simple bifurcation, you want to rotate only the main vessel. You rotate the left main LED and then you don't rotate the circle.
Great. I know we're running a little bit late, but I would ask you to stay on because Roberto saved the best for last. Burr entrapment is the one that, you know, and there've been questions that scares us the most. So if you can, please stay on a little longer because I think you'll enjoy seeing how Roberto got out of this. Thanks, Roberto. Please carry on.
Oh, okay, so we have the last point. The Burr entrapment is the most, we know we have many sort of flow chart for Burr entrapment. This is one of your intervention to go with the balloon alongside the bird that is entrapped. I don't like this situation because you have a great risk of perforation, and because if you have an entrapment of the burr, you are in a complex situation with the heavy calcification and the burr inside of the vessel. If you go with another wire and the balloon inside, you increase the risk to have a perforation. You can push and pull, but you increase the risk of left main dissection or to lose everything. So we start to use this kind of technique to use mother and child for Burr entrapment, and we have 100% of success. We didn't have any problem to remove the burr in this situation. This is a case of entrapment of the burr is a 175 burr. As you can see here, I have the problem with the audio. Was a radial, you can see, and this is the technique. You have to use a scissor to remove the sleeve. So you cut the system completely, you remove the sleeve, you have the burr trapped in the artery, so it's easy. Then you put mother and child inside of the burr, outside of the patient, and you have the best of support because your burr is entrapped in the artery. So you can push the mother and child. This was a Godzilla coming, you can see. And you go in front of the burr. No way to avoid this situation. Because you have to go that. So once you don't want to go over the burr because it's impossible. You go close to the burr and then you pull everything out. You have the most of force here at the level of the burr. You can see, and then
from the ostium of the right. And this was the final result. Another, okay, sorry, balloon stent, and then another situation. LAD, huge calcification, primary rotablator with 1.5 burr, the IVUS doesn't cross. I was able to cross with 1.5, and then I make the mistake. We perform IVUS. With IVUS, we said that the result was not good with the 1.5. We have to increase with the 175. We have an entrapment.
90% final result. So to avoid burr entrapment, don't stop the rotablation inside the plaque. Be coaxial, and respect the burr to artery ratio, and don't go with the big burr in some situation like the last case. And to solve the entrapment, pull the burr and have a deep intubation. Use mother and child after cutting with the scissor the system, and disassembly this system. So this is the best way to solve the problem. Thank you very much.
That was excellent, Roberto. I love that video because I think it's a really important trick for the colleagues on how to get themselves out of trouble. You know, in the past we would try, I mean, one of the easiest ones is just to pull back on the wire and see if that will disengage. But in the past we used to try to go next to the burr, the entrap burr, with a wire, balloon. It would take forever. The patient's becoming ischemic. I think this is a very elegant way of getting out of it. Antonio, did you have any comments on that technique?
No, I think it's a very elegant technique and makes a lot of sense. One technique, as you said, pulling back on the rotablator wire sometimes works. So I think is underutilized. But as you know, the tip of the rotablator wire is 18 and will not go inside the burr. So by pulling on the wire, you may dislodge a little bit the burr and may come back. I would not do that while activating the burr, because that's the best way to cut the wire. If you do that and you activate the burr, you're going to lose the tip of the wire in the corner. But if you don't activate the burr and pulling a little bit with the wire, you may get the burr out, and that's easy. But otherwise, what Roberto showed with the mother and child is very, very effective. But you have to use rotablation. You have to do 2 or 3 rotablation a month. Because if you don't do it, you don't learn and you don't solve problems. So don't be afraid. The number needed to treat for rotablation is not 1. Do 10 rotablation, 3 of them were essential and 7 of them were not essential. In medicine, don't look for number to treat 1. Does not exist.
Also because if you select only the worst cases, you have high risk of complication, and you select all the worst situations. So I agree completely with that. Because we need to have 5 to 7% of cases with rotablator. It is not high number, it's not high percentage, but it's good.
Yeah. The best way to improve your case record is to do some healthy cases. So don't learn from the surgeon.
So there were 2 questions, and I'm sorry I'm interrupting, Miguel, but because they're from a friend of ours from Max San Giorgi, there are 2 questions. First thing I want to say is hi, Max. We're great that you can join us. So Max had 2 questions. The one was, how many cases end up with dissection after burr entrapment? And also, have any of you had experience with the new rotablation system in your thoughts?
Yeah, for the new rotablator, yeah, I started to use 2 years ago the new RotaPro. It is I think it's very good for people who start using rotablator from the beginning, because they don't used to have pedal, and it's quite easier. But it's also good for people who knows to use the traditional one. The problem is that when you're performing, when you use the new RotaPro, when you push the button is on. You have to know that you have to push again, because normally when you have the pedal, you remove the pedal and the rotablator is off. In this case, you have to push again the button. Otherwise, it's continues to run the burr. And for the dissection, you can have dissection in this situation, but if I remember, is less than 10% in this case of burr entrapment. So you treat burr entrapment. I have all successful retrievement of the burr, and if you have a dissection in a small number of cases, you need to solve the problem after that. But If you are not able to remove the burr, you need to go to the surgery. So this is very important to know that.
Dr. Garbo, if I may ask just a couple of last questions. The first one is, believe it or not, here in the Bronx, we see a lot of plaque rupture ACS presentation in a previously very calcified vessel, and often we're unable to expand balloons or able to adequately dilate the lesion. Do you encounter the situations there, and do you ever use rotablator in ACS?
Yeah, this is a good question, Miguel. We have some, I think, two different situations. The first one in which you are able to restore, like in STEMI, you are able to restore symmetry flow, and you have a proximal calcified lesion that you are not able to treat, to dilate. I suggest in this case, if you restore the symmetry flow, to postpone the rotablator like 48 hours later. So you have a good antiplatelet activity of your drugs, and you can do rotablator in the elective situation. But if you have some situation which you are not able to open the vessel, or you have obliged to do that because you have a thrombus, and you are not able to cross with the thrombus aspiration, and the result is not good, or you have subocclusion later, and the flow is TIMI2, and you can do rotablation in this situation. Is not the best, but you know that you can do that. Very small burr, 125 in this situation, in order to crack a piece of calcium that after that you can dilate easily and put a stent. So it's not a high number of cases, but you have to know that you can do it. If you can, it's better to postpone to after 2 days, I think.
And there was a question earlier that was reiterated now. When you're doing a rotablator case, any sign that you should look out that may tell you early on that you might have burr entrapment in the next pass or in the current pass? How do you recognize that, and what do you do? Yeah,
you have to be very careful to the noise of rotablator, because when you have to look at the number of run, if decreasing more than 10,000, the risk of entrapment is very high, and then the noise of the burr change. So you have to be with experience. You know that when you have a reduction of burr run and the change of noise, you have the risk of entrapment. That's why I told you, when you are in this situation, you have to go back fast, proximal to the lesion, and then to stop the rotablator, and then to increase or change the burr, have a downgrading, or increase the high speed. If you increase the speed, like you are 150, you have this situation, you go to 180, and you try again, and normally you avoid, and then you have to increase your coaxiality. This is very important. You have not to start to rotablator to rotate with the manifold in the mid of the system. You have to be at the back, because the burr have to be really close to the sleeve. So if you are not coaxial, this is another situation which you can increase the risk of entrapment.
Roberto, could you show the video again of how you cut the burr and put in the guide catheter extension? I'm going to ask, while you bringing that up, if Antonio has any final comments, and then we'll let you show that video and we'll end there.
Okay.
Antonio?
No final comments. I think the lecture of Roberto was excellent. The discussion was very appropriate, and I think rotablation is underutilized, and make sure to use it more. That's my comment. Use it more.
Okay, this is the video. You cut with the scissor the system. You remove the system rotablator. You go on with you remove the sleeve. and you can put your guidezilla or guide liner or whatever you want inside of the rota wire that is connected with the burr. You can see here with the left hand of my colleague that it holds the wire, and I push the guidezilla.
Yeah.
And then you can go with the guidezilla. You can advance in the artery. You can see, and you go up in front of the burr, and then you can pull everything.
Excellent. Excellent.
So
thank you.
No, thank you, Azim, and thank you for your fellow and Antonio. It was a great pleasure and everybody was attending the meeting. You have a great idea. You are great, Azim. So thank you. Congratulations for your idea, and thank you very much.
Thank you.
And see
really
next time to CTO complication.
Exactly. We're looking forward to that. Okay.
Bye-bye.
Okay. Bye-bye. Bye-bye, everybody.